Pierre-Robin sequence. What is Pierre-Robin sequence? It is a congenital craniofacial condition that affects the lower jaw, the palate, and the upper airway. It is not considered a syndrome or a disease. It was named after the French dental surgeon Pierre Robin. In 1923, he first published a case of an infant with the characteristics of the malformation of the lower jaw and receding chin, the glossotosis of the tongue, upper airway obstruction, and cleft palate. Pierre-Robin sequence was previously known as Pierre-Robin syndrome or Pierre-Robin malformation, but it is now correctly named a sequence since 1974. The term sequence was introduced to be used for this condition because one initial malformation leads to the chain of events causing the other anomalies. In the case of Pierre-Robin sequence, it starts with the underdeveloped mandible that leads to the abnormal displacement of the tongue and the formation of a cleft palate. In contrast to versus a syndrome, which is a set of anomalies that arise separately due to one underlying factor. The etiology of Pierre-Robin sequence, the exact cause is unknown. It is not genetically linked, but it may be isolated or part of a syndrome, also known as syndromic PRS. There is a higher incidence in twins, which may be due to the crowding of the uterus, which restricts the growth of the mandible, and that causes the sequence that Pierre-Robin sequence is known for, the malformation of the jaw, the displacement of the tongue, and then the formation of the cleft palate. So this is considered, PRS is considered rare as an isolated event. It is present in about 1 to 10 to 14,000 births. And it is equally common in males and females, like I said, with the higher incidence in twins. This is also very common to coincide with syndromes, such as the Stickler syndrome or Treacher-Collins syndromes. PRS is associated with 34 syndromes and is an underlying disorder of that syndrome. So another etiology of PRS is normally between 9 to 11 weeks of gestation. That is when the tongue moves down and away from the roof of the mouth. This allows the space for the sides of the palate to shift to the midline and close. But in PRS, the small mandible keeps the tongue positioned higher in the mouth than normal, which interferes with the normal closure of the palate. This is what causes that wide U-shaped cleft palate. There are 3 theories associated with the pathogenesis of PRS. There's a mechanical theory, there's a neurological maturation theory, and a mandible compression theory. Here is a slide that showcases how the primary anomaly causes the sequences leading up to the ending with the palate. And right here you can see it starts with the hypoplastic mandible, the malformation of the lower jaw, and here's the glossotosis with the tongue being more bulbous towards the back of the throat, which obstructs the palatal fusion and then causes that U-shaped palate. The diagnosis of Pierre-Robin sequence is there is no diagnostic test, but there is some genetic testing that can help rule out PRS as a secondary factor of the other syndromes, like I mentioned, Treacher-Collins, and the Stickler syndrome. Prenatal diagnosis can be detected on ultrasound due to the underdeveloped jaw and mandible. Also, the presence of maternal polyhydramnios, which is the absence of adequate amniotic fluid, which causes the glossotosis. It hinders the development of the tongue. Also, advanced imaging can allow to calculate the jaw index, the size of that, and where it lies on what's normal growth and what is abnormal growth according to the gestation period. But usually diagnosis is made at birth with a physical and clinical observation. So what that would include the micrognathia, the glossotosis, and the airway obstruction. Cleft palate is common into 90% of the cases, but it is not required for the diagnosis. The main diagnosis for Pierre-Robin syndrome is micrognathia, glossotosis, and airway obstruction. Imaging is utilized, such as X-rays or CT scans, to assess the severity of the condition. The classification of Pierre-Robin sequence can be considered mild, moderate, or severe. Here is a slide showcasing the live births with Pierre-Robin sequence and how they come out looking. Here's that underdeveloped chin and receded chin, retrognathia, and you can't see it, but here is a good picture to show that how the tongue is obstructing the airway because it's basically grown backwards. And then the cleft palate, because of the high arch, because of the tongue, it's causing that cleft palate. All right, symptoms and complications. Symptoms, like we talked about, for which are the same as the diagnosis, is the small jaw and the receding chin, the downward displacement of the tongue, and airway complications. And then major symptoms are the cleft palate, because it's present in 90% of cases. Complications are feeding difficulties, airway obstruction, ear infections due to the presence of the cleft palate. It doesn't allow proper drainage of fluids from the middle ear. There are dental abnormalities, malocclusion, crowding, and underdevelopment, or even supernumerary teeth. There are speech and language delays, facial growth and aesthetic concerns. Most babies born with PRS commonly experience trouble breathing and feeding early on. That's resulting from the tongue's position, the smaller jaw size, and the cleft palate formation. Other issues are slow weight gain due to poor nutrition, and there's also hearing problems. The treatment for PRS, the most important concern for babies with PRS is safe breathing and protecting the airway. When a baby with PRS lies on their back, their tongue falls back and blocks the airway at the back of the throat. How much a child's breathing is affected depends on the severity of the PRS. If PRS is mild, there may be no airway concerns, but as severity increases, the concerns of safe breathing increases. Treatment is usually done in phases and is from multiple specialists that overlap in conservative and surgical approaches. Here's a nice treatment overview tree that explains the evaluation, the management, and then the classification of mild, moderate, severe, and the treatments that are recommended for which classification they fall into. Conservative treatment measures. A baby with mild PRS and few airway problems usually do well with positional adjustments on their stomach, as that allows the tongue to fall forward and out of the airway. If positioning doesn't work, there's also a more conservative route of trying a nasal trumpet, which is a small tube placed in the nose to improve airflow and into the upper airway. When it's effective, it can prevent or avoid surgery. Infants with PRS A conservative treatment route is to never put them on their back because that makes the tongue fall um, to the back of the airway, which can block the airway. Baby must be able to breathe well in order to feed well. Any breathing or airway problems have to be addressed before baby can feed effectively. Holding your baby in special positions can help with feeding. And if a baby has a cleft palate, feeding with specialized bottles and nipples for those bottles are very helpful for cleft palates. Surgical intervention. The most common surgical intervention is a surgery called distraction osteogenesis. This is more for severe forms of PRS that need surgery to help the baby breathe. This happens when less invasive measures fail to improve breathing and feeding, and this is where surgery is required. Most children who have PRS benefit from this procedure. Distraction osteogenesis, which is the bones of the jaw are cut and lengthened with the use of a metal device, and it gradually stretches the jaw over the course of about 2 weeks. And this helps reposition the tongue and improves the baby's ability to breathe. Here's a nice picture of how the jaw is cut and the metal device is placed, and how osteogenesis, the building and formation of the bones, those osteoclasts, remodel and form in and extend the jaw. And this is done early on because it's the baby's growing. Okay. Here are some before and after surgical treatments from at birth and or infancy. We can see how there is maldevelopment of the chin, and with the surgery, the chin is now becoming protrusive. The prognosis of PRS. The study found that mortality rates for babies with PRS were highest during their first year of life. But even with that challenge, the survival rate during that first year was really impressive at a 96% survival rate. Even more is researchers followed those kiddos over a course of 10 years and found that the overall survival rate remained high at 95.1%. And this really highlights the importance of early intervention from birth, and that babies with PRS have a remarkable ability to overcome early hurdles and live a long, bright life. They do have to be mindful that in adulthood, sleep apnea is very prevalent, and most children have normal speech after palate repair. And of course, with no surgical intervention or treatment at birth, the survival rate is very low. There has to be some type of intervention for these babies to survive. But if it is intervened, the survival rate is high. Here's a case report of an adult before and after. This is a 16-year-old, but he was born with PRS as a baby. He had the cleft palate, a small jaw. He had trouble breathing and eating, and he actually required a tracheostomy and a feeding tube. So he was from a mild to severe case. He had immediate intervention as a baby. He had a repaired cleft palate, and at the age of 2, he underwent the distraction osteogenesis surgery for his lower jaw. He was able to get his tracheostomy removed. He was able to begin eating normal, and he no longer needed the feeding tube. He continued to grow with speech therapy, orthodontic care, and is able to talk normal now. He is doing well in school. And here are pictures pre and post-op of his most recent surgery for his persistent small jaw and chin. Some dental hygiene considerations are frequent cleanings to prevent and monitor oral health, upright positioning during procedures, frequent breaks, and possible supplemental oxygen through a nose cannula during procedure. Here are my references that I used. And I want to thank you for your time, and I really enjoyed learning about Pierre-Robin syndrome. Thank you so much.